Hello and welcome everyone to our latest journal review of the paper which has been recently published in NEJM, that is Therapeutic Anticoagulation with Heparin in critically ill patients with COVID-19. This is a study which has involved these three platforms, that is the REMAP-CAP, ACTIV-4a and the ATTACC platform. In this multicentric international study was done. The three platforms harmonize their methodology and statistical analysis so that we can pull the data and get a much better study. The inclusion was all the three patients include patients who were hospitalized COVID-19. In this study, they included the severe COVID-19 patients, which was defined as those who needed ICU level care, that is needing respiratory or cardiovascular support. Respiratory means high flow nasal oxygen, NIV or invasive ventilation, or cardiovascular in terms of vasopressor or anotropes and requiring an ICU stay. Now, admission of more than 48 to 72 hours was an exclusion criteria. Patient with imminent risk of death, no ongoing commitment to full organ support, high risk of bleeding, dual antiplatelet therapies, patient who were needing therapeutic anticoagulation for other indications, with patient with history of heparin sensitivity like HIT were excluded from this study. The randomization was 1:1 in the ACTIV-4 study. However, in the other two study, it was adapted every month. The intervention. Therapeutic anticoagulation was administered according to the local site protocol for the treatment of acute venous thromboembolism for up to 14 days, and it was until recovery, defined as either hospital discharge or discontinuation of supplemental oxygen at least 24 hours. Usual care was administered at a dose and duration determined by the treating clinician according to the local practice, which included either standard low dose thromboprophylaxis or enhanced intermediate dose thromboprophylaxis. Outcome. The primary outcome was organ failure free days as evaluated on an ordinal scale, indicating the number of days free of cardiovascular and respiratory support up to day 21 among patients who survived with hospital discharge, which means that if the patient did not require any organ support till day 21, then it was taken as 21, and it was 0 if the patient was on organ support on admission and continued to be on organ support at the time of day 21, and patients who had a mortality were treated as -1. Results. Now, total 13,373 patients were assessed for eligibility. Out of this, almost 10,000 were considered ineligible because of various exclusion criteria, some 2,000 requiring therapeutic anticoagulation on its own, nearly 730 having high risk of bleeding, and other exclusion criteria. 2,244 had moderate disease who were treated at a ward level, and there is a separate analysis for this. We will come to that later. So total 1,207 patients were randomized, 591 into the therapeutic anticoagulation, 616 into the usual care thromboprophylaxis. And if we come to other exclusions, then total 538 were included in primary analysis in the therapeutic group and 564 in the usual care group. Now, the demographic was roughly same in between the two groups. The age was around 60, mostly male patients, white, and patient involving critically ill. Most of the patients are coming from the REMAP-CAP, that is 80%, and with almost 70% from UK. The median body weight was 30, APACHE 2 was 14. In terms of pre-existing disease, most common pre-existing disease was diabetes mellitus. The baseline organ support they were requiring was mostly high flow nasal oxygen and NIV. That is 2/3 and 1/3 were on ventilatory support. Total vasopressor requirement was around 20%. The mean PF ratio was 120. Now, if we look in terms of the D-dimer levels, it was elevated, that is more than 2 times elevated in 50% of the cases. If we look at absolute value, the mean value was around 850. Rest values were roughly similar between the two groups, not much difference. Now, if we look at the outcome, what they found, the organ failure free days was similar between the two groups. There was no significant difference seen. This is same even in terms of survival to hospital discharge, major thrombotic events, major bleeding risks. However, the benefit that was being expected with therapeutic dose anticoagulation was not to be seen in this subpopulation subgroup. Now, the limitations of the study was it was an unblinded study, and one very important thing is that UK at that time was recommending intermediate dose thromboprophylaxis as a national guideline. So the patients in the usual care group were receiving the intermediate dose. Other co-interventions like tocilizumab and steroids, they could affect the result, and the result has not been standardized for intervention from these drugs. Now, if you look more closely into the study in terms of anticoagulation that was actually received, then only 77% actually have received therapeutic dose anticoagulation, while almost 23% did not receive therapeutic dose anticoagulation, even though they were randomized into the therapeutic dose group because of the local practice variations. Now, in the usual care, most of the patients did receive the usual care, while 6% received therapeutic dose, and as high as 50% were receiving the intermediate dose. Now, in terms of thrombotic events, it is quite significantly more in the usual care group, especially almost double the value. 42 patients had thromboembolic events in the usual care group, while only 13 patients had in the therapeutic group. Myocardial infarction was also more in the usual care group. The conclusion, according to the authors, was that in critically ill patients with COVID-19, an initial strategy of therapeutic dose anticoagulation with heparin did not result in a greater probability of survival to hospital discharge or a greater number of days free of cardiovascular or respiratory organ support than usual thromboprophylaxis. The probability that the therapeutic dose anticoagulation was inferior to usual care thromboprophylaxis was quite high. Now let's see what did they find in terms of the non-critically ill patients, that is the moderately ill patients. The study was almost similar, everything was similar. The inclusion here was different, that is the included patients who had a moderate disease, that is who did not require ICU level care. In this, they stratified the patient into three groups: a high D dimer group, that is more than 2 times the upper limit of normal, and the low D dimer group, that is less than 2 times the upper limit of normal, and an unknown D dimer level. Again, here, if you look at the baseline, it was roughly similar between the two groups. And here, as you can see, most of the patients are again male, and the age is slightly lesser compared to the severe group. It is 60 around, that was 70 around. In terms of the race, most of the patients are white. The body mass index was again same, around 30. Most common comorbidities were similar: hypertension and diabetes. Organ support over here in terms of respiratory was mostly low flow nasal oxygen, but they did have some patients who were on high flow and non-invasive ventilation. The rest are roughly similar between the two groups. But if you look closely, again, most of the patients here are coming from the other trials, that is the ATTACC and ACTIV-4, compared to REMAP-CAP, which had only 10% of the cases. So in this, most of the patients are getting enrolled from US, that is 50%. So if you look at the outcome, it is showing a benefit for the therapeutic dose, where you can see the organ failure free days are much more in therapeutic dose group compared to the usual care group. And this, the odds of getting a benefit with therapeutic dose was higher in patients who had a high level of D dimer. Now, if you look into the secondary outcomes, that is hospital discharge, organ support free, progression to intubation, major thrombotic events, most of them were showing favorable outcome for therapeutic anticoagulation. Now, same thing being represented in a graphical form. There was less organ support requirement, less NIV2 or invasive ventilation requirement, less intubation and death, with superiority probability of almost 90% or more for therapeutic dose anticoagulation. This benefit was seen across all the subgroups, but if you look at the ventilated patients, though the patients on ventilator were not supposed to be included, 45 still were getting ventilated, and they did show benefit of receiving therapeutic dose anticoagulation. If you look at bleeding events, The fatal bleeding events were much less, only 3 in therapeutic group and 1 in usual care group. Not much difference in terms of bleeding. In terms of thrombotic events, we do find a significantly higher risk of thrombotic events. That is, pulmonary embolism was also higher, and MI was again similar. So the take-home message, because of the conflicting report, is what is to be known is that the pathophysiology of COVID-19 definitely has immune thrombosis as a major cause of organ failure and hypoxia. So as far as if we combine both study, then definitely we should give therapeutic anticoagulation in the early stage. Now, as we all know by now that the hypoxic stage is most likely because of the immune thrombosis process that is going on. Still, the alveoli are most probably not involved. So that is why we should get a benefit at early stages of giving therapeutic anticoagulation. However, how long this process continues, does it actually subside at a particular point in time, is difficult to predict right now. So should we stop this therapeutic anticoagulation that we have started at an early stage? This point is not yet very clear, because as we have seen in the study in the critically ill patient did show a very high risk of thrombotic events, didn't really show any significant demerit, that is, any significantly increased bleeding risk. And at the current moment, we still don't know at which point of time in the process of pathophysiology this immune thrombosis process actually ceases. So we cannot have a timeline as of now when we should stop the therapeutic anticoagulation and maybe switch over to prophylactic anticoagulation. But considering our practice where we have seen patients developing thrombosis at very late stages, even after 1 month, we would continue to give the therapeutic anticoagulation as our protocol in all patients who are getting admitted to the ICU. Thank you for your patience, and check our website for further information.